We're going to get started. Sorry for the delay. It's great to see so many of you out here today. I am Rachel Werner. I'm the Executive Director of the Leonard Davis Institute of Health Economics, and we're here today for the Leighton Memorial Lecture. And actually, to start things off today, we're going to hear a little bit about Dr. Leighton from his wife, Mrs. Leighton, and two of his children. We're so happy that you can join us here today. So I'm going to invite you up.
What a crowd. This is a really treat. This is a big treat. Hello, my name is Pam Leighton, and Charlie Leighton was my husband. I'm so proud of this lecture given by an endowment from Merck and Company to honor Charlie for his contributions to Merck for 29 years. The first lecture was in 1994, and Dr. David Kessler, who was then the head of the FDA, was the speaker. It was very appropriate as Charlie had worked with Dr. Kessler personally. At that time, it took 14 years for a new drug to be approved by the FDA. Today, for our 30th lecture, we have the renowned Dr. Ezekiel Emanuel speaking on creative rejuvenation of transforming American healthcare. Both he and Charlie were graduates of Harvard Medical School. I must confess that I did have to look up the meaning of bioethics, as Dr. Emanuel is the world's leading bioethicist. What I discovered is that it's the study of ethical, social, and legal issues that arise in biomedicine and biomedical research. Now, I would like to introduce my three children. Wendy will be speaking on this, and Christy and Chip are here to join me today.
Wendy first.
Wendy is back there.
There she is.
It's frozen.
Good afternoon. My name is Wendy Leighton. I think my father would be thrilled that Dr. Emanuel is today's speaker. He is clearly a leader in healthcare transformation and an advocate for those marginalized in our society. I am particularly interested in Dr. Emanuel's views on reducing costs and availability of life-saving medicine, on aging, as well as end-of-life care. These are often conversations families and society keep silent or suppress. He recently tweeted how 1 in 48 women are dying in low-income countries from breast cancer, knowing as an oncologist these tragic deaths are preventable. I agree that we must do more to access healthcare for women in these countries, as well as our own country. Many healthy Black, Brown, and Indigenous women are still dying needlessly in hospitals giving birth due to inadequate care and lack of attention. He also brings to light the struggle of those living with AIDS in the gay community, which is of great interest to me. An AIDS patient, Andrew, is an example of moral medical dilemmas in his book, The Ends of Human Life. Even though Andrew's wishes were written on a note given to his partner expressing his desire to avoid a miserable death, his estranged parents wanted to enforce their wishes to prolong their dying son's life. Medical ethics are important topics of conversation we must have. I dream of the day when people in the LGBTQ+ community will have their wishes honored without question, including myself and my long-term partner. In conclusion, I welcome Dr. Emanuel and hope you enjoy his presentation. And may you afterwards have meaningful discussions at lunch about these important issues and how we as individuals can make a difference starting today in our own families and communities. I know my father would encourage this. Thank you.
Hello, my name is Christy Leighton, and I'm Charlie Leighton's younger daughter. I'm so delighted to be here in person and to be part of this 30-year anniversary of this important lecture series. This year is truly a milestone for our family, and it means so much that the Leonard Davis Institute here at the University of Pennsylvania has committed to giving this presentation for the past 3 decades. To put this in a more personal perspective, When I first attended this lecture in 1994, I was pregnant with boy-girl twins. This year, my son and daughter are 29, and I'm in the midst of planning my daughter's wedding. How time truly does fly. It has been a tremendous honor to have so many prestigious guest lecturers present here. I have learned so much from the various speakers in the fields of medicine and healthcare. Today, we are thrilled to have Dr. Ezekiel Emanuel return to speak to all of us. I again want to extend my sincere thanks to the amazing team at the Leonard Davis Institute who take the time to plan and execute all the details of this wonderful event. Our family is so appreciative of your hard work each year. Thank you all for being here today.
And I'm Chip Leighton, the youngest of Charlie Leighton's three kids. And I know my dad would have been proud of this lecture series and excited about it. He was a strong believer in education and also in science. And I'm sure he's been looking down and smiling at all these wonderful lectures. And I know he'd be fascinated by Dr. Emanuel's talk today. My dad loved hearing about new ideas and debating them. And so I know I'm looking forward to hearing more about this concept of creative rejuvenation, and I'm sure you all are too. So thank you for joining.
Once again, I want to thank the Leonard Davis Institute for their efforts on over 30 years to recruit such renowned speakers with distinguished careers in the fields of science and medicine. It is indeed an honor working with you and my family. I look forward to listening to our exceptional speaker, Dr. Emanuel.
Thank you so much to the Leightons. It's always so wonderful to hear directly from you and have you participate in today's event. I want to briefly introduce Zeke Emanuel. You've heard a lot about him already, but Zeke, as you know, is a bioethicist and an oncologist. He is right now the Vice Provost for Global Initiatives, the Diane V.S. Levy and Robert M. Levy University Professor, and also the co-director of the Healthcare Transformation Institute here at the University of Pennsylvania. He served as the founding chair of the Department of Medical Ethics and Health Policy here from 2011 into 2020. And prior to that, served as a special advisor for health policy and the director of Office of Management and Budget in the White House. And before that, as chair of the Department of Bioethics at the NIH. He has written, edited 14 books, published over 300 articles, and is one of the world's most cited bioethicists. We are thrilled to have you join us here today, Zeke, and I will invite you up and look forward to your remarks.
I want to thank the Leighton family and thank Rachel for having me here. I will tell you, as everyone was talking, I was thinking, there's another interpretation of creative rejuvenation, which I'm not going to talk about. It's sort of biological one. I'm talking about some practices and really practices related to the healthcare system. And so that's really, it's not about rejuvenation, pig hearts or whatever. That's not my field, and I'm not going to discuss this. This is a work in progress in the sense that this is my 15th book idea. I'm still working out all the details. I'm pretty sure I've got the right direction, but a lot of the details are wrong. I look forward to your comments, suggestions, and corrections so that I can get it. Don't be shy. As I always tell everyone, whatever you say, my brothers say 10 times worse to me. I can take it. Since 2009, the uninsured rate has plummeted from 50.6% to 7.7%. We will certainly go up because of the recertified people in Medicaid, but we have made tremendous progress there. In 2024, we have over 21 million people in the insurance exchanges, aka Obamacare, and more than 5 million came in brand new in 1 year. Medicare Shared Savings Program, which was written into the Affordable Care Act, has actually saved 6 straight years. The last year, 2022, that we have data for, it saved $1.8 billion. And that's statistically significant difference from what had been projected. There are 480 MSSP ACOs in the country, and about half of the traditional Medicare beneficiaries are now in an ACO. Most of the practices actually are earning bonuses because they actually are doing really well. And the best performing practices are able to save 10%, pretty substantial savings in the American health system. We've got moving further and further towards value-based payment, with most policy experts, including myself, think it's absolutely essential if we're ever going to control costs. And since 2010, as this nice graph printed in the Times shows, we've saved $3.9 trillion, basically by the dog that didn't bark. This line here, I'd like to show the trend. That was what was predicted by CBO. And the other line that breaks around 2010 is what actually the spending was. So that's a huge amount of savings actually in the system. It's always hard to predict, how much have we saved? Well, it's hard to know what's the counterfactual. I will just say, I don't want to pat myself too hard on the back, but in 2014, I did predict the end of healthcare inflation. I thought this scenario was very, very likely to happen. Now, on today's Friday? On Tuesday, I was at a big conference celebrating the Affordable Care Act's 14th anniversary. It does happen to be tomorrow, so you can break out your champagne for it. And a lot of the co-conspirators, people I work with, who helped get that law, Nancy Antiparro, Peter Orszag, John Blum, and many, many others, were there, and they were looking at these statistics and showing these statistics and repeating these statistics and sort of patting themselves on the back. See what a great achievement the Affordable Care Act was. Really substantial reform that has made a big difference in the country. And there is this view, the sort of American booster, and this is actually a direct quote. We should realize that whatever its flaws, the American healthcare system is the best in the world. After all, if you get sick, there's no other place in the world you want to be treated than in the United States. That is a direct quote. It happened about 10 months ago at a conference I was at, actually uttered by a Penn graduate who was retired CEO of a major healthcare company. And I was like, not my experience. In fact, my experience is that most Americans at the moment are bitching and moaning, excuse the French, about the American healthcare system. In 2010, most people who are in this room would have been somewhat happy with their situation in the American healthcare system, even if they were concerned about coverage, about cost, whatever, but they could get the care they wanted. Since that time, I've noticed that most of the people like us in the room, that is upper middle class, well-educated people, actually can't stand the system and have more complaints about it, and because they're more vocal than most Americans really moan. And as Gallup survey says, first time in Gallup's 2-decade trend, less than half of Americans are complimentary about the U.S. healthcare system, with 48% rating it as excellent good, but the majority saying not so hotsy-totsy. I think actually dissatisfaction is a lot higher than the American Food Service suggests, and a lot of people thinking, care somewhere else might actually be better. There are plenty of failings. Without the temporary boost from COVID policies, which are going to go away, we're certainly going to have health coverage is going to be at 90%, not less. Costs are still enormous, $4.7 trillion. And I just happened to look up yesterday, maybe some of you keep this in your mind, the World Bank figures about GDP around countries. We have now surpassed both Germany and Japan in terms of our healthcare spending is bigger than their entire GDP. So the American healthcare system is now number 3 in the world. It will never be number 2, and probably, it can't be number 1. That's theoretically impossible. And the outrageous thing is that in 2024, family health premiums are just shy, literally less than $50 from $24,000. That seems to me a totally outrageous number. You know, that's roughly the poverty line. It's like, that's what we're paying. And we all know that quality is uneven, but tends to the poor. You know, going back to that American booster, this is the thing always trotted out. I'm an oncologist, as Rachel said, so I'm very proud of this. This looks at the cancer rates, five-year survival, rigorously compared all across the world with the same methodology used on their data. And you can see that the United States does very, very well. The arrows point to where we are. Well, it doesn't points to where we are. We do very, very well at 5-year survivals in general. We're actually #1 in breast cancer. But there are, this is cancer. That's, I would say, the only place where we're like, we are the world's leader. Take almost anything else, hypertension. You know, this is super important. There are 110 million American adults who have hypertension, 10 million who don't even know they have high blood pressure. According to the CDC, less than 25% of adults with hypertension have it under control. I don't know your standard, but that's definitely an F in my class. Okay. High blood pressure contributes to 700,000 deaths per year or more. That's more than cancer. We're only at 600,000, right? And the tragedy is that I can't think of very many diseases that are easier to treat except the ones that are, you know, basically cure themselves, right? Like the flu. This is diabetes. We have about 38 million Americans with diabetes, and 36.5 of them have type 2 diabetes. 10 million, again, don't even know that they have diabetes. High quality care, you know, it's basically, you got to do 4 things. Control the blood glucose and hemoglobin A1C. Control the blood pressure. Make sure the cholesterol's down and patient's on a statin. And have the patient have an annual eye exam and an annual foot exam. 22% of diabetics have the first 3 under control. That's it. Just like hypertension, we're doing a miserable job. Not that complicated a disease also. Infant mortality. You know, this is shame, shame, shame. The United States infant mortality rate is 5.5 per thousand. We have about 3,600,000 births a year. That's about 20,000 deaths. Among 49 countries reporting to the OECD, these are rich countries. 36 countries have lower mortality rate than the United States, right? U.S. has 3 times the infant mortality of countries with the best results. Places like the Netherlands, Norway. Maternal mortality. This is a little more controversial. Some of you may have noted. The traditional figure is that our maternal mortality is about 33 women per 100,000 births die, with African-American women way higher. And again, we're way higher than the OECD average and way higher than the Netherlands, Japan, Norway, places that really have basically almost no maternal mortality. Now, recently, there was a controversial article published literally 3 weeks ago that those numbers aren't quite right, don't reflect actuality. I don't know where the truth lies. I haven't mentioned lots of other areas. So there's cardiac care, stroke, chronic kidney failure, rate of avoidable deaths, obesity, where we do just a terrible job. It really is poor performance, nothing for us to be proud of. So yes, in cancer, we are, as the American booster says, fabulous, but in the rest of it, we're not. And the question is, how do we understand that? Despite spending more than any other country, despite the fact that we have basically an unlimited amount of money, we can't achieve either universal coverage or consistently high quality of care compared to our peers. There is something deeply wrong about the American system. We can talk about any individual one of these things, but part of what creative rejuvenation is about is what is the underlying fundamental problem that leads to this and makes it so hard to solve? That's what the question I'm asking. And is there a way to identify that problem and try to fix it So, we have a problem of coverage. We've had a problem of coverage for more than 100 years. We have developed a whole series of ways to cover employer-sponsored insurance. We went that route during World War II and after the war, mainly because we didn't want to go, we thought that single payer system or some government sponsored program was akin to, being communist and being red. We were in the midst of the Cold War, and that's the option we took. We left out two big groups, the people who didn't have a job and the elderly who were retired from work. So we developed programs beginning in the late 1950s, advocating for Medicare because the elderly were a very appealing group. It took almost 10 years, but we finally got Medicare for the elderly because of Lyndon Johnson's massive electoral landslide in 1964 and his masterful work as a legislator. The French actually honored him as the greatest legislator of all time. And he was able to pass it despite opposition of the American healthcare and medical establishment. Then we expanded it, adding ESRD to 1972, the disabled and patients with ALS or Lou Gehrig's disease. We also passed Medicaid for poor, but we restricted it. We didn't cover all the poor. We covered all pregnant women, children, the elderly who were poor, the blind and disabled. We still had big gaps. We tried to reform in 72. We tried to reform in 93. Nothing got through. In the failure of the Clinton proposal, we got chipped because Ted Kennedy and a Republican, Orrin Hatch from red Utah, came together and said, we're going to cover low-income children whose parents who weren't poor enough to get Medicaid, but whose parents earned too much but did not have employer-sponsored insurance. We've had VA coverage for around 9 million vets. We've had actually some version of that for most of the 20th century. And we have a separate healthcare system for them. Many of them are dual eligible. They're eligible for Medicare or some other program, but the VA covers them. TRICARE for soldiers and their family. Indian Health Service, again, developed a post-war for the Native American population as part of our obligation to provide for them. The federal employee health benefit, we're going to provide have employee-sponsored insurance. The federal government has more than 2 million workers. In the late 50s, early 60s, we instituted the Federal Employee Health Benefits Program to give them coverage. And then in the Affordable Care Act, we still had this enormous level of uninsured, 15% of the population. We instituted the exchanges for some of the uninsured individuals. Anyone can go in there, but the subsidies are limited to some of them. Now, again, you might say from one vantage point, the program succeeded. I did mention the Hill-Burton Act. It was something we passed in 1946, right after the war. Lots of men showed up at the military draft, totally inadequate physical specimens with many sort of latent health problems that we hadn't taken care of, parasite infections and other things. Recognized that 40% of American counties didn't have a hospital or access to a hospital. Hill, some of you may know this history, Lister Hill was a senator from Alabama, but a New Dealer. He wanted to improve his constituents. And Burton was a Republican from Ohio. They came together and they passed a bill. And for 30 years, they financed the expansion of community hospitals. They made federal matching grants available to communities to build hospitals. And they built 6,800 hospitals in 4,000 communities, partially or exist because of the Hill-Burton Act. Then Medicare, 66 million people insured. In 1960, before Medicare was passed, the elderly poverty rate was 35%, drops now to below 10%, largely because Medicare took the healthcare bills off the table for older individuals. CHIP, 7 million children getting coverage. ACA, we, as I said, reduced the uninsurance rate from over 15% to 10%, under 10%. Part D expanded what Medicaid beneficiaries have and reduced the financial burden on them. You know, you might say, big success, right? Big success. At best, partially true. There's also some element of serious failure. If we're spending $4.7 trillion, we still have 10% uninsured and we can't get quality. Part of that is, I would argue, how we fix coverage. We have all these programs, right? We're always adding more. Add, right? You know, Kennedy and Orrin Hatch can't figure out what to do with the children. Rather than put them into Medicaid, add another program, right? The uninsured, we're working on the Affordable Care Act. Rather than put the uninsured into Medicaid or figure out how to expand Medicare for those people, add another program, the exchanges. We're always adding more. Now, creating programs to cover more people can address the immediate problem. Get these low-income kids who don't qualify for Medicaid coverage. But adding programs creates complexity and tends to perpetuate, even exacerbate, some of the underlying problems. Adding programs tends to spawn new issues, creating further complexity and opportunities for gaming. Complexity, I would argue, breeds complexity. It turns out that this add more is very innate human tendency. This is one of the most fascinating articles I've read in like the last 10 years. These are researchers who gave people like us problems to solve. And almost invariably, when we solve problems, we add something. We do not say, oh, how can I actually subtract and solve this problem? That's not an intuitive approach we have. And it turns out that's not intuitive even when you're told you might subtract. You're reminded, you're given some financial incentive to subtract. And of course, our addition bias is worse, as you might imagine, when we're under time constraints and we have cognitive load from other things going on when they're more or less distracting us from asking us to think through. This additive default in human beings is one of the reasons we expand by adding new programs. Now, I think, and this is, you like to say, this is the money slide. You understand the slide? Sit down, okay? Incremental solutions, adding programs to solve a portion of the problem. This is the American approach, right? We got the Medicare for the elderly, Medicaid for the poor. We expanded Medicare, threw in, ESRD for people in renal failure. Why did we do that? Because some guy got in front of a very powerful House Ways and Means Committee, dialyzed himself there, and it's like, why wouldn't we let anyone do this? And Wilbur Mills expanded Medicare. Incremental solutions create fragmentation and they create complexity of the system. You end up with different programs, different eligibility requirements, different benefits, different payment levels, different quality metrics, on and on and on. And, I was present at creation of the Affordable Care Act and the expansion of Medicaid. The eligibility requirements don't match. The income we use doesn't match. The benefit levels don't match. Fragmentation and complexity add to the public, the people who are trying to get coverage, time, effort, cognitive load, figure out what they're eligible for. Complexity also facilitates system-wide waste and inefficiency. You have multiple prices, leading to high administrative costs, leading to lots of effort to comply with all the different requirements. And I would argue that fragmentation and complexity inhibit more comprehensive and systemic reform, permanently institutionalizing the fragmentation and the complexity and resisting any systemic reform. So again, this is the flow diagram of the money slide. you have lack of coverage, the solution is to add more coverage, partial coverage programs. The programs at their best ameliorate part of the problem. None of them have gotten us to universal coverage. There's no way, even under the best of circumstances, that the Affordable Care Act is going to get us to universal coverage. New programs create fragmentation and complexity, and that leads to time, effort, cognitive load for people, fragmentation of all the other parts of the healthcare system, especially payment, complexity, system-wide inefficiencies and administrative costs, and gaming opportunities. The more complex a system, the more opportunity for groups to come in and game what's going on. Just look at PE and their roll-ups. That's nothing more, I hope I offend someone here, nothing more than a gaming opportunity. That's all that is. And you end up with new problems needing fixes, surprise medical billing, just to give you an example. And you need, you end up with sclerosis of the system. Just give you an example. On average, customers of the exchange have 113 plan options to choose from for the plan year. The average Medicare beneficiary has 60 Part D plans to choose from, some freestanding, some part of Medicare Advantage plans. Those of you who know even an inkling about behavioral economics know that so many choices, right, lead to paralysis. What happens when you have too many choices? I don't know about you, but I turn around. It's just too much when you do. And it leads to bad choices. So there's experimental studies. You can pick your favorite, but my favorite is if they present health plan choices to people and they ask them to maximize the situation. You give average people 4 health plan choices and they select the best option for them economically and covering everything they need 42% of the time, and they overspend by $200. Give them 8 choices, much less 113, and they do even worse. Half the number actually select the best option. We're now wasting $325, right? So this is a formula for not optimizing the situation, what we've created. Choice complexity exacerbates the uninsured rate too, right? So not only does it lead to bad choices, it actually is counterproductive. So it turns out if you look at the uninsured people, Kaiser Family Foundation and some of this, right? 60% of the non-elderly are eligible either for an exchange program or a Medicaid program, right? You could actually substantially reduce our uninsured rate by 60%. Almost 5% of that uninsured would go away. But 22% of those reporting said, look, I didn't enroll in a marketplace exchange or Medicaid because it just was too complex. I couldn't navigate it. I didn't have the time to navigate it. And 64% said they can't find an affordable option. Now, just remember, only about 25% of the uninsured are actually eligible for Medicaid. If 64% said they can't find an affordable option, right? That has to be wrong. It can't be that high because they're eligible for Medicaid, which doesn't cost them anything. Something is amiss here. A lot of that unaffordability is I just can't figure this out. Must be too expensive. Complexity in coverage also leads to complexity in payment. This is the famous New York Times graphics. I hope you all read those series of articles. Almost a year old now, or 6 months old, something like that. What is August 21st? Yeah, okay, 8 months old, right? These are different places in the globe where they, in the country, where they're pricing colonoscopies, looking at what major insurers pay, what the cash price is, and you can see the line 4 times the Medicare price. Basically, they're all over the place, right? The prices are just, ridiculous. Columbus, Ohio, almost, Florida, of course, $6,000. And you can see no consistency among insurers, etc. When you have lots of different payers, right? Not just Medicare and Medicaid, but you have all those different employer-sponsored private insurers, you get lots of different prices. So we've got fragmentation in coverage leading to fragmentation in payment and multiple prices. So when hospitals are asked, produce your price list, there's no such thing as a price list. That's a ridiculous request, Congress. Thank you very much. We have multiple price lists, okay? And that complexity in payment, the multiple prices, the lack of consistency among employer-sponsored insurance leads to administrative inefficiency, complexity, and waste. $950 billion of that $4.7 trillion is actually administrative costs, right? Hospitals alone account for $250 billion in administrative costs. I don't know exactly. I have to ask Kevin. How many people in billings and claims do we actually have at University Health System? At a lot of systems, it's now more than one person per bed. Just McKinsey estimated about a quarter of that, maybe a little more, maybe a third, is could be saved. It's administrative waste. Now, some of that can be saved by the hospital being more efficient, and there's a lot of good examples of that. But much of the waste is because of the multiple prices, because of the multiple prior authorization processes, claims processing requirements, causing the need for administrative personnel and costing billions of dollars. There's also lack of incentives to adopt automation and AI for repeated tasks. This is more an internal activity, both in insurers and in hospitals, but that is a very common problem. I would argue that the fragmentation of payment has also contributed to the slow uptake of value-based payment. We have a lot of different payers and providers. There's no single payer has sufficient share of the provider panel to force a change. You know, even big behemoth United Healthcare for most plans is less than 20%. For most providers, is less than 20% of their panel. It doesn't pay people to focus on 20%. Also, if they adopt value-based payment from one payer, another payer is likely to have a different kind of program with different incentives and different structure. And if you adopt value-based payment and you end up adopting changes to maximize that, you might actually lose money in your fee-for-service program, and that actually doesn't make sense for you from an economic standpoint. So this multiple payments, multiple payers creates an inhibition to adopting value-based payment. Now, there is some belief, a lot of belief, that, well, Medicare is the big behemoth in the room and they can drive change. Partially true, partially not true. Partially true is they are a big behemoth, and that was part of the reason created the CMMI, the Center for Medicare and Medicaid Innovation. They could develop new programs like value-based payment and push them out. But in some areas, they don't actually have a lot of leverage. Yes, they have a lot of patients, but the fact of the matter is they're not the profit margin. They're not where people make profits. They are more interested in their commercial, because they're commercial insured patients, because that's where they're actually making money. And there are some spillover effects from Medicare payment, but it hasn't led to lots of consistent programs by Medicare and the private payers. The efforts to induce private payers to adopt the Medicare program to actually drive a lot of the revenue and increase the leverage on providers, generally I would call it a failure. We've got complexity in quality, right? Every insurance company, exchange, regulatory agency has their own quality metrics. You know, just take Medicare. They are using 788 different quality metrics across 34 programs. Right? You've got fragmentation even within a single payer. Now they're trying to reduce that. It's going to be a very important effort, but it's long in coming. And again, complying with the different quality metrics adds to administrative cost and inefficiency. I would argue that this also adds to clinician burnout. We're seeing tons of burnout. 50% of physicians and nurses or more are burned out in surveys in 2023. If you look at all the different causes they rank, number one is the administrative tasks. The fact that they have to do more, fill out more paperwork, and comply with more things. In fact, on the electronic health record, American physicians spend at least 50% more time on the electronic health record than Europeans, because we're spending more time doing it. All right. And so the fragmentation of payment leads to a lot more administrative burden on doctors, which leads to burnout. All right, gaming opportunities. Okay. It also inhibits innovation. Actually, on Monday, we were meeting with a venture capital group to talk about ideas for innovation around prior authorization and payment. And they basically said, look, the problem of doing this is, whatever insurer we go to in almost any place is going to have 10% of the patient panels. It's hard to get the attention of doctors to change their program for just 6 or 10% of their patients. And therefore they were like, this is good idea, but no market. And that, I think, is a consistent theme. Those of you who have seen lots of new things, startups spend an enormous amount of time navigating each individual system, each individual payer. Now, fortunately for many startups, selling something to United is usually a great payday, but it's not a great way to change the American healthcare system. So yes, it might be innovative for United. They'll buy you and kill you, and then no one will ever see it the light of day, but it won't change the American healthcare system. This is what it looks like, and this is the simplified version. This is my good friend Jonathan Cohen. Did this to try to explain the American healthcare to New Republic readers in 1993. It's only gotten way more complicated. So I think it also leads to this process of systemic sclerosis. You've got a problem, you add solutions because of the addition default. We end up with fragmentation because this is America, leading to complexity, leading to lots of problems. And then we have this problem of you can't change anything. Fragmentation of coverage and payment create extensive systems that they become entrenched. Any change, right, is resisted. Even minor modifications to the existing system often get resisted. It becomes impossible to make underlying substantive changes to the system. I think that there are 4 main barriers I would identify. One, you have entrenched institutions. They're created. You have to either work with them. You can't just destroy them. We'll talk about that. Entrenched interests, public loss aversion, and timid incremental reform, right? I mean, look, this is the skyline, right? If you really want structural reform, you just can't pluck out one. Yes, maybe we can destroy the Empire State Building, take it down and pull it away. But you can't, knock down all of these. And that's what you'd have to do, as the Clintons, realized, if you really wanted underlying structural change. And that wasn't possible, isn't necessarily, right? It's possible to create new programs. We can create something where there wasn't something before. That's how we did Medicare. That's how we did Medicaid. That's how we did the exchanges. They didn't exist. So you can add. It's basically, empty ground. We can plant something new. Once a program exists, they tend to grow and become institutionalized, resisting modifications. And solutions to problems can add work to get around the flaws. The political scientists call this path dependence. You've got a bunch of institutions, you can't change the institutions, and so you have to work around them. We also have entrenched interests, right? Those who benefit from the status quo constrain or co-opt reforms to maintain their benefits. Hospitals, physicians, insurers, drug companies, PBMs, PE firms, every other actor, right, uses their power to maintain their benefits, even as they know reform is needed and they observe that the rest of the system is deteriorating. Look at various different actors. PBMs, I haven't seen their stocks drop tremendously despite talk about regulating them. Why? Because they figured out, this rebate thing, I can make my profit some other way. There's enough area. The drug companies, oh yeah, you're going to regulate their prices. We'll have higher introductory prices. We've extended out. You can't touch a drug until it's been on the market for 9 years for pills and 13 years for biologics. Okay, by that time I, just jack the price up and it'll come down at the end, so I won't make money at the end. Academic health centers, we're not immune either. Every talk of we're going to adjust DME and IME, That's the graduate medical education money or the indirect money for training, right? We're gonna chop so that the trainees we produce better match the needs of the country, more primary care doctors, more specialists in particular areas, right? What happens? They call up the senator from New York, they call up the senator from Massachusetts, where there are lots of medical schools, senator from Pennsylvania, and they make sure nothing happens. It's been on the docket for 30 years that we should change DME and IME, mostly to cut, but even if you simply wanted to reform it to better reflect what we need, no. Public loss aversion. Despite dissatisfaction of the system, Americans fear change to the system will make them worse off. This is not unique to Americans. This is, again, another general human tendency, as Kahneman and Tversky showed. And, you know, if you need no better example, go back, search in Google for the Harry and Louise ads. Now, some of the people, a handful of the people in this room, right, are simply too young to remember. My researchers, right? But some of us have lost enough hair that we remember those ads. And I have to tell you, they're remarkable. So they were run when it looked like, wow, Clinton reform might actually have a chance. And Chip Kahn, who was then, I forget which organization he was with at that point, Chip Kahn developed these ads and basically made Americans who hated their insurance company, we always hate our insurance company, made the insurance company look lovable. Really like, oh, if we could only have our own insurance company. They are remarkable. You should go back and look at them. And what they really do is play on this idea of loss aversion. And they are amazing. I talked to a reporter just the other day on Wednesday about, go back and look at this. This is why it's so hard to regulate drug companies, the Harry and Louise phenomena. And there are recent losses that justify the public fear, like abortion and other enrollments. Then there's timid reformers, basically dysfunctional Congress. Incremental and additive change, as I mentioned, is possible occasionally. You know, we went a long time between Medicare and Medicaid, even Part D, and the Affordable Care Act. Comprehensive reform is harder, and the benefits of comprehensive change take years to materialize. In the interim, the public's anxious and dissatisfied. You know, I will just remind you, I am very pessimistic about comprehensive reform for this reason. After the ACA, Democrats lost 4 straight elections, 2010, 2012, 2014, and 2016, right? Politicians, they have one goal in life, re-election. They don't like losing. They don't like being unemployed. When the Democrats passed the ACA in 2010, right, 61 members of the House got voted out of office.
Wow.
61 members of the Democratic Party, excuse me, got voted out of office. That sends a message like, I'm not doing this again. Only in 2018 did we finally, right? The ACA had to be in place, right, for 10 years or 8 years before the public came around. You know, this is pretty good, right? And a lot of upper middle class people got immediate benefit. We passed it in March. By September, their kids were retained on their insurance program, right, at no additional cost. Pretty good deal for those parents sending their kids to Penn. But we couldn't switch around the public's attitude in general. Now, let me just say, I think this issue of fragmentation causing complexity, causing sclerosis, turns out to be very common in all public systems. This is just, I stole this from a guy at Urban, just published an article about this problem. He didn't label it the way I analyze it, but he talks about the multiple problems. Here it is. All the food programs, right? TANF, Temporary Assistance Needed Families, SNAP, food stamps, National School Lunch Program, School Breakfast Program, early Head Start and Early Head Start with food programs, right? Everything has multiple programs. Student loans. We've got, I think, 29 different student loan programs, right? We've got complexity, right? Try to get rid of them. Not likely. Try to consolidate them. Very, very hard. All right. That's my pessimistic view. Is there any element of optimism? How do we fix sclerotic systems? Well, if you're a business theorist, right? Say, well, there's creative destruction, a process in the marketplace where innovation makes the old way of doing things obsolete, and you just kill that firm, right? The new produces a fundamental reform of the structure of a business process, suppressing and superseding the old. Think about automobiles replacing the horse, digital cameras replacing film, personal computers replacing mainframe. Electronic cars are inevitably going to replace internal combustion cars, not without a lot of government help, but at least, well, automobiles had to have government help too. Nonetheless, we have creative destruction in business. I would hypothesize or propose to you, we can't have creative destruction in social systems like healthcare, like education, like taxes, or housing policy. You can't just level the playing field and then have something replace them. They are too entrenched and control the situation. So I'd say creative destruction works for business in the market. It can't work for social systems. Destruction of a few healthcare companies. Some of them go out of business, or even entire hospital sector will not cure the fragmentation and complexity of coverage, payment, quality metrics. Creative destruction will not fix the entire healthcare system. Okay, so I don't think we can destroy our way to a better healthcare system. We just don't think that's possible. So my question is creative rejuvenation an alternative way to think about it? Is it possible to enact comprehensive structural changes that remove institution-wide structural defects, replace them with new institutional arrangements that solve persistent problems without destruction, but through some rejuvenation process? Under creative rejuvenation, the system does not continue with the same fundamental institutional arrangement. Okay, is that possible? So I would say that one approach to solving the fragmentation that I have suggested is to look at Netherlands, Germany, and Switzerland. They have multiple insurers, but they don't have our problem. And how do they do that? How is it possible for the Netherlands? They have 22 different insurers. Germany has, last I counted, probably out of date. It's probably just below 100 now, but it was 109, I don't know, 5 or 7 years ago. Switzerland, I forget how many they have because they're canton based. Could we go to their system? They don't have the same cost problems. All of them are about 6%, at least less than we are on a GDP basis. They have consistently higher quality than Netherlands. One of the higher quality in terms of diabetes control, maternal mortality, etc. So what they have that we don't is universal coverage. Everyone has to be in. By the way, in Switzerland, if within 2 months, if you have not bought insurance, they will garnish your wages for the equivalent of the health insurance premium. No muss or fuss. You're just taking it out of your paycheck. You may not want it, but it doesn't matter. They have government mandated standardization of benefits, deductibles, copays, quality metrics, etc. Yes, you've got separate payers, but you have lots of standardization that prevent the fragmentation and therefore prevent an element of the complexity. And their view is without preventing innovation. In Germany, it's really hard to find innovation. Netherlands, it's not so hard. I think universal coverage and standardization is necessary. One of the questions I have, and I don't know the answer to it, is it sufficient? Would that do it enough? Would that evolve to where we need to go? There's also this further question. All right, maybe that will be, we'll run the experiment. How do we get there? How do we get to universal coverage and standardization in the current system? All right, I got one example for you. I think I have two, but I'm just going, time is short, so I'm going to give you one, right? And this is Philadelphia, right? The 1787 Constitutional Convention. Why did we have the Constitutional Convention? Because we had an institutional structure called the Articles of Confederation, which sucked. I mean, they just were terrible, right? They had representation by state. Every state had one vote. You couldn't amend the articles. Every legislation required a supermajority, 3/4 of the states. There was no ability to raise funds for a central government. States were jealous of that. No common monetary system. No ability to conduct a national foreign policy or provide for the common defense, and no ability to regulate trade with other countries or even between the states. It was totally unsuccessful. So we created a constitutional convention. 55 delegates representing 12 states met in Philadelphia in a hot summer for 3.5 months. Anyone know the state that didn't show up? The history test, history quiz.
New York.
Very wrong. Rhode Island. It's always Rhode Island. Early history is always Rhode Island. Subsequent, the Civil War and beyond, it's always South Carolina. Okay. Safe guessing though. James Madison and others had spent time preparing. They studied, Madison studied an extensive study of constitutions to figure out what was essential. He brought a detailed proposal, but he wasn't the only one who had a detailed proposal. Importantly, in my view, they had confidential negotiations. It was a hot summer and they nailed the window shut. There were people outside trying to listen in and find out what they were saying, but they didn't tweet, right? They didn't anonymously leak to the press. They didn't write newspaper articles. They didn't make any public comments. And the goal wasn't to reform the articles. The goal was to create a new institutional structure for the federal government. They quickly got to agreement on the broad brushstrokes. 3 branches of government, president. They bogged down on representation by state or population. That's how we got the bicameral business, right, as a compromise. They bogged down on the presidential election and exactly how much power the president would have. And they, of course, bogged down on slavery and the slave trade. Each one of these almost busted the thing apart, constantly on the brink of failing. They had a proposed constitution with an amendment mechanism, up or down vote by each state, and a requirement that the constitution had to be approved by 9 states to be enacted. States use different methods of adoption: popular referendum, meetings around the state, vote by the legislature. The glaring issue of Bill of Rights was taken off the table. Madison said, all right, the first thing we'll do is create a Bill of Rights. What are the essential elements? You might take a different view of the history. I think a clear goal. This is what we want to get to: universal coverage with effective cost control and higher quality, consistently high incentives for higher quality care. We want a wise, trusted group of delegates. We want a few settled areas of agreement, like there will be universal coverage, there will be standardization, secrecy without constant public pressure, seclude them, willingness to compromise. For those of you who are history buffs like myself, you might read the final speech at the Constitutional Convention, which was not actually turned out not to be a speech. It was by Ben Franklin, 713 words. It won't take you 5 minutes to read, about the importance of compromise, the importance of listening to others, the importance of not thinking you have all of the answers, but that this will have to evolve, and a mechanism to adopt a plan with changing circumstances so it's absolutely flexible. I do think these are what, we can't very broad, right? Freedom of expression, what the hell does that mean? So we work it out over time. We can adapt it, we can modify it. All right, that's my speech. I'm over time, so I'm not going to go through the conclusion. You can listen to me and like David.
So we're moving over time. I don't know if there's any burning questions.
I'd love to hear burning questions. I need ideas.
Two of your early slides mentioned there were large numbers of people who didn't know they had.
Yeah.
Well, if they don't know, how do you know?
Because you enroll people, or you enroll people in a study, and then you measure their blood pressure, and lo and behold, their blood pressure is high, and it's not actually. You have to do just a random selection of the population. We didn't do it, but the British did it with COVID. Just go out into the street and test everyone for COVID, see how many people knew they had COVID and how many people didn't. You know what the latent infection rate is. Yeah.
So in your analogy with the U.S. political system at that time, do you think people just thought, hey, we can get a better deal economically?
No,
You don't think it was an economic analysis?
nope, nope. I reject that, and I think most historians reject that. It was not viewed. States were jealous. Most people didn't know about the other states, couldn't care. You remember, travel was by horse and buggy or walking. People did not know.
Yeah, but you had things like interstate commerce.
No, they did not experience interstate commerce. Most people did. They were very, very local, extremely local. Most people live within about 10 miles of their house for their entire lives.
Tell me if this is too left field. I'm also a cancer person in the cell and gene therapy space. With these high cost treatments, the
Yeah.
one we just saw this week, right, $4.25 million.
Yeah.
Offered at 5 treatment centers is the game plan over the US with 50 states with 50 different Medicaid programs. Do you think that the evolution of these treatments could kind of be a good force of change on the Medicaid system? Thinking about the cell and gene therapy model out of CMMI.
No,
Great.
I don't think, and mostly because I don't think it's big enough. It's just not a.
Repeat the question.
Cell and gene therapy, you've got now cell and gene therapies for $4 million. Would it be a big enough impetus to shift? So one of the slides I took out because I hadn't fully developed the ideas. Look, we just had COVID, right? A once in 100-year pandemic killing 1 million people, right? Will the system be any different post-COVID? Well, most of the reforms around telemedicine, payment, cross-state, blah, 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 going away. There will be some residual telemedicine. We're all experienced on it. Getting home care instead of going to the hospital, we're going to get more of that. Will it fundamentally change the structure of the healthcare system? Absolutely not. We've made a very concerted effort to make sure that doesn't happen. So I am not at all optimistic that an internal shock, as it were, a shock inside the medical system is going to be enough to switch it. I think it's got to be external. Now, I worked with Vic Fuchs, who's one of the giants of American health economics and American health policy. He used to say, you know, you can get these big shifts with 3 things: war, depression, or both. I'm not even sure that's true. I just, you know, we got the ACA during a very bad economic time. COVID was really stressed to the system. Nothing is going to stick. Not part of that is, you know, you can blame Trump. He didn't take it as an opportunity to change things, but you can also blame the Bidens. They didn't actually take it as to put permanent changes. Every one of the changes we did was temporary. We did. They did. I wasn't there.
I read a book written about 15 years ago. One of the authors was a doctor right here at Penn, you may know, and he suggested like a 10% sales tax to pay for insurance for everybody in the country, but instead, like, we went with the Affordable Care Act. Do you find out? Do you think that was too much destruction in that suggestion to have?
No. 15 years ago, I had suggested also a value-added tax. That idea has been around for a very long time. The tax alone will not. Again, if you think the underlying problem is fragmentation and beginning with fragmentation of coverage, that'll get you revenue, but it won't shift the underlying structure of the system. Part of what I'm saying is we always think about it in terms of money. I don't think it's fundamental. We have more than enough money. $4.7 trillion is more than enough money. The problem is the institutional structure that makes $4.7 trillion necessary. That's what has to be changed. Until you change that, I think we can constrain how much we're going to spend, but we're not going to be able to bring it down to 12%. Last question.
Seems there's a fundamental conflict of interest between the insurer deciding who to reimburse and the fact that, of course, they benefit from not reimbursing. So, I mean, might a lot of the inefficiency just be actually by design, a factory to waste people's time until they go away?
No, I don't think I do think it's by design once you've got an insurance company and once you give the insurance company these kinds of incentives. But the problem is before that. That conflict of interest is created by not having standardized design, standardized prior authorization, or however you want to do it, standardized limits that they have to adhere to. So yes, there's going to be this profit maximization mode. They have it in Germany. They have it in Netherlands. They have it in Switzerland. They're still able to do things we can't do, get universal coverage, et cetera. And that's because they have oversight. They have solved some of the problem that we have created and perpetuated. And so yes, we're always going to have that conflict, and I don't think that's going away. We have to create a system where that is not as pernicious as it is today, would be the way I'd put it. Okay? All right, thank you very much.